This part of the Toxicologic Investigations section will be focused on tricyclic antidepressants. Here's our case to start. This is a 21-year-old woman who was found with decreased level of consciousness. Her heart rate on presentation was 154 beats per minute, blood pressure 102/62, respiratory rate 14, oxygen saturation 98% on room air, and a temperature of 37 degrees Celsius. Her GCS was calculated to be 11. What test should be ordered now to help differentiate if this is a toxicologic exposure? Let's think back to the types of investigations that should be considered for patients presenting with a possible toxic ingestion. With a completely undifferentiated exposure like this, it would be reasonable to order basic blood work to be able to calculate an anion gap as well as an osmolar gap. An ECG and urine toxicology panel, as well as some basic serum drug levels including acetaminophen level, ASA level, and ethanol levels were also done for this patient. There was no immediate indication for radiologic testing, and so this was deferred. Blood work has been sent for this patient, and the lab results are pending. An ECG becomes available and shows the following. Describe the main ECG findings, and think about if this suggests a specific type of toxin. This ECG shows a number of key findings, including sinus tachycardia, a wide QRS complex, and a large secondary R wave in lead AVR. An ECG showing sinus tachycardia, a wide QRS complex, and a prominent secondary R wave in lead AVR, as well as other features of right axis deviation and a deep S wave in lead 1, should be a clue to the presence of a sodium channel blocker. There are a number of drugs that have sodium channel blocking properties. Probably the most common in use are tricyclic antidepressants. Other drugs include type 1A antiarrhythmics, including quinidine and procainamide, as well as type 1C antiarrhythmics like flecainide. Other drugs with sodium channel blocking properties include local anesthetics like bupivacaine, antimalarials including chloroquine, as well as hydroxychloroquine, which is also widely used for a number of rheumatologic conditions, as well as propranolol, carbamazepine, and quinine. Going back to our case, we now have additional information that there was an empty pill bottle found next to our patient. This was labeled as containing amitriptyline with a maximum potential ingestion of 25 milligrams times 90 tablets. This would equate to a total dose of greater than 35 milligrams per kilogram. This leads us to our next few questions. What is the potential toxicity of tricyclic antidepressants? What is the best first test to order for suspected tricyclic antidepressant overdose? And what is the role of urine or serum toxicology testing for TCA overdose? The main features of tricyclic antidepressant overdose are ventricular dysrhythmias and seizures due to blockade of sodium channels in the myocardium and CNS, respectively. Other features include sedation that can progress to coma, hypotension, tachycardia, and features of an anticholinergic toxidrome. It is helpful to think of TCA toxicity based on the receptors that are affected. For example, TCAs mediate their cardiotoxic effect by blocking myocardial sodium channels, producing the characteristic wide QRS complex and tall R wave in AVR on the ECG. Similarly, it is sodium channel blockade in the central nervous system that produces seizures. This brings us to our first follow-up question. Other than sodium channel blockade, list 6 other mechanisms of action of tricyclic antidepressants and the resulting signs and symptoms. What about the best first test to assess for TCA toxicity? Because of the characteristic ECG findings due to sodium channel blockade, an ECG should be taken in all patients that present with TCA overdose, as well as those that present with a deliberate self-poisoning or altered level of consciousness of unknown cause to screen for possible TCA toxicity. The ECG is both diagnostic and prognostic in TCA overdose. A limb lead QRS complex greater than or equal to 100 milliseconds is associated with an increased risk of seizures. A QRS complex greater than or equal to 160 milliseconds is associated with ventricular arrhythmias. Looking for an R to S ratio in lead AVR greater than 0.7 may even be a better predictor of arrhythmia than the QRS interval. Urine and serum TCA screens are often used and available. However, it is important to recognize that these screening assays are limited by poor specificity and frequent false positive results. For example, several other drugs including quetiapine, carbamazepine, diphenhydramine, cyclobenzaprine, cyproheptadine, and phenothiazine will all cross-react with the TCA assay. Therefore, a positive TCA screen does not necessarily mean that TCA toxicity is present. Let's move on to the management of our patient. Remember our patient's first ECG. Now look at a second ECG that was done after a treatment was given to our patient. What has changed between the two ECGs? For our follow-up questions, what treatment was given prior to the second ECG, and how should this treatment be given? Next, what is the treatment for seizures, and what drugs should be avoided in the context of TCA overdose?